So let's discuss about pruritus in pregnancy, and we'll begin with intrahepatic cholestasis. It occurs in second and or third trimester, and it rapidly resolves after delivery. It is most common liver disease unique to pregnancy, and reported incidence range from less than 1% to 27.6%. Okay, so there is wide range of variation in the incidence. And what are the clinical presentation? It is heralded by the development of pruritus, which ranges from mild to intolerable. It is often generalized, but generally starts and predominates on the palms and soles and is worse at night. Right upper quadrant nausea, poor appetite, sleep deprivation, and steatorrhea may occur. Okay, I am telling that steatorrhea may occur. Okay, pruritus and other symptoms usually develop during the late second or third trimester. Transient first trimester symptoms have been linked to ovarian hyperstimulation syndrome after in vitro fertilization, while persistent and worsening symptoms are characteristics of naturally conceived pregnancy. Okay, so do you get it or not? Transient first trimester symptoms have been linked to ovarian hyperstimulation syndrome after in vitro fertilization, while persistent and worsening symptoms are characteristics of naturally conceived pregnancy. And on physical examination, we can find scratch marks, excoriations, prurigo nodules secondary to scratching, but no primary skin lesions are associated with disease. Jaundice can occur in up to like 14 to 25% of patients, typically developing 1 to 4 weeks after onset of itching. Jaundice and pruritus without pruritus is rare and should prompt investigation for other cause. And what are the lab investigations? What we get on lab results? Increase in serum total bile acid concentration. It is present in greater than 90% of affected pregnancy and may be the first and only laboratory abnormality. Pruritus may precede laboratory abnormality. Other potential laboratory abnormalities include increase in serum aminotransferase, which are usually less than 2 times upper limit of normal but may reach values greater than 100 units per liter, making distinction from viral hepatitis important. So if it reaches a value greater than 1000, then we have difficulty distinguishing whether it is due to hepatitis, viral hepatitis, or whether it is due to pregnancy that is causing this cholestasis. And alkaline phosphatase may be inhibited fourfold, but it's not specific for cholestasis during pregnancy. Why? Because expression of placental isoenzyme that may confuse, and total and direct bilirubin concentrations are elevated in 25% cases, although total bilirubin rarely exceeds 6 mg per deciliter. And the gamma GT is normal or modestly elevated, like in 30% cases, which is unusual in most other forms of cholestatic liver disease, in which gamma GT levels parallel other cholestatic markers. Okay, so gamma GT may be normal or it may be modestly elevated, which is unlike other cholestatic liver disease in which gamma GT level parallel other cholestatic markers. I repeated it once again so that you will remember it. And prothrombin timing usually normal. Okay, primary bile acids are cholic acid, chenodeoxycholic acid. Okay, which are conjugated with glycine or taurine before being secreted in bile. And cholic and chenodeoxycholic acid levels are increased, but cholic acid increases more than chenodeoxycholic acid, resulting in marked elevation of cholic to chenodeoxycholic acid ratio compared with pregnant women without intrahepatic cholestasis of pregnancy. However, most women with elevated bile acid ratio also have elevated total bile acid levels. As a result, obtaining a ratio does not enhance diagnostic performance. And when doing ultrasonography, it is not associated with any abnormalities. Histopathology is characterized by cholestasis without inflammation, and diagnosis is based on presence of pruritus associated with elevated total serum bile acid levels, elevated aminotransferase, or both, and absence of disease that may produce similar lab findings and symptoms. Although some variation in lab criteria exists among guidelines, severe cholestasis is consistently defined as bile acid over 40 microgram mole per liter and accounts for about 20% of cases. Because pruritus can rise in can precede rise in serum bile acid by several weeks. We suggest repeating lab tests weekly if total bile acids and aminotransferase levels are initially normal. However, if ursodeoxycholic is started empirically, elevated bile acid and transaminase level may never be detected. And diagnostic evaluation, and what are the differential diagnosis of this condition? So the differential diagnosis of pruritus and hepatic dysfunctions in pregnancy we should think in mind. And what are the pregnancy specific cause of pruritus? What are, if there is any pre-existing cause of pruritus or any pregnancy specific cause of hepatic impairment or pre-existing cause of hepatic impairment. So this all comes in our differential diagnosis of intrahepatic cholestasis. Let's talk about pregnancy specific cause of pruritus like pruritus gravidarum. It occurs in third trimester, and ectopic eruption of pregnancy which occurs in first trimester, and polymorphic eruption of pregnancy. It is also mainly in third trimester. Pemphigoid gestationis, itchy rash, and it also occurs in second or third trimester. And there is also rash that develops into large and tense blisters. Okay, and it is associated with a number of complications like increased risk of preterm delivery, small for gestational age, and it may recur in subsequent pregnancy with combined oral contraceptives. So this is about pemphigoid gestationis. And other differences are prurigo of pregnancy. Prurigo, groups of red-brown papules on the abdomen and extensor surface of the limbs. Papules may persist postpartum. And pruritic folliculitis of pregnancy. Iconiform eruption of shoulders, upper back, thighs and arms. Okay, and there may be other pre-existing cause of pruritus like atopic dermatitis, allergic drug reaction, and systemic disease like liver, renal, thyroid disease may also cause pruritus. And what are the pregnancy specific cause of hepatic impairment like acute fatty liver of pregnancy, hemolysis elevated enzyme and low platelet syndrome, HELP syndrome, hyperemesis gravidarum, and acute fatty liver of pregnancy. Women with acute fatty liver of pregnancy are more unwell and often have associated renal impairment, coagulopathy, hypoglycemia, and preeclampsia. Okay. So there will be also other causes like pre-existing cause of hepatic impairment like viral hepatitis, primary biliary cirrhosis or primary sclerosing cholangitis, autoimmune hepatitis, drug-induced liver injury, biliary obstruction, veno-occlusive disease. Okay. So these are differential diagnosis you should keep in mind. And what are the fetal effects? What is the morbidity, mortality, and then we will discuss about treatment, how to treat this. Okay. So let's discuss about fetal effect. Maternal bile acids cross the placenta and can accumulate in fetus and amniotic fluid, which carries significant risk to the fetus. Transplacental gradients facilitates fetal clearance of bile acids in normal pregnancy but are reversed in cholestatic pregnancy, which causes accumulation of bile acid in the fetus and amniotic fluid. The main complications are increased risk of intrauterine demise, intrauterine fetal death, meconium misted amniotic fluid, preterm delivery, and neonatal respiratory distress syndrome, which are appears to be associated with bile acid entering the lungs and cause respiratory distress. So you have to keep these complications in mind because it is associated with a lot of complications, this intrahepatic cholestasis. Okay, and now let's move towards treatment. So our goal is to reduce the symptoms and reduce the risk of perinatal morbidity and mortality. So treat all patients with intrahepatic cholestasis. For patients with characteristic clinical symptoms but normal serum bile acids and aminotransferase levels, either empiric treatment may be initiated or laboratory tests can be repeated weekly with initiation of treatment once total bile acids or serum amino and transaminase levels or both are elevated. Okay. So orthodeoxycholic is preferred treatment of maternal pruritus due to intrahepatic cholestasis of pregnancy. And for refractory cases, like if maximum dose of orthodeoxycholic acid and pruritus remains intolerable, other drugs like adenosylmethionine, cholestyramine, rifampin can be tried. And we do pregnancy management, antepartum fetal assessment with twice weekly modified by physical profile, although value of antepartum fetal testing to identify fetus at risk of demise in the setting of intrahepatic cholestasis of pregnancy is unproven. And timing of delivery, so early delivery to reduce the risk of fetal demise and to initiate disease resolution. Timing should be guided by balancing the risk of fetal death with expectant management against the potential risk of prematurity with early delivery. So generally at 36 plus 0 or 36 plus 6 weeks gestation or upon diagnosis of, if ICP is diagnosed at 37 or more week of period of gestation without performing an amniocentesis to check fetal maturity prior to delivery, so we generally deliver at that age after 36 weeks. Okay. So this approach is based on data from retrospective cohorts that sought to determine the risk of perinatal mortality with delivery versus expectant management, stratified by gestational age, week between 34 and 40 week gestation. Okay, so this is a brief history from where we have extracted this data. So delivery prior to 36 week of gestation. When we do this, if excruciating and unremitting maternal pride is not relieved with drugs, there is jaundice, a prior history of fetal demise before 36 weeks due to intrahepatic cholestasis of pregnancy with recurring ICP in the current pregnancy, high total serum bile acid concentration greater than or equal to 100 micromole per liter. Determination of bile acid concentration may take several days even in major laboratories, making it an impractical tool for immediate risk stratification. So timing of delivery in this situation is empirical and generally delayed as long as possible after 34-week gestation, depending on the individual's patient's particular circumstances like symptoms, gestational age of previous fetal demise, values and preferences. All patients electively delivered for intrahepatic cholestasis of pregnancy prior to 36 weeks are extensively counseled about the absence of definitive evidence that the maternal and fetal benefits of ending the pregnancy outweigh the potential morbidity of prematurity. Okay, and now we discuss about outcome, maternal outcome. Postpartum cause pruritus disappears in first few days following delivery. Okay, and intrahepatic cholestasis is not contraindication to breastfeeding, and ursodeoxycholic acid is discontinued when labor begins. Okay, and we check liver biochemical test and bile acid concentration 6 to 8 weeks after delivery to confirm that previously noted abnormalities have resolved. If lab abnormality do not return to normal, the patient should be referred to hepatologist to assess for underlying hepatobiliary disease. Okay, and cholestasis recurs during subsequent pregnancy in about 60 to 70% of women with ICP. Recurrent episodes are variable in severity compared with the index pregnancy. So, and now we discuss about contraception. Any non-hormonal contraception may be used. Estrogen, progesterone. When you give these kind of hormones to women with history of ICP, rarely results in recurrent cholestasis. Thus, combined OCP can be initiated after normalization of liver concentrates. However, women should be informed of the possible development of pruritus or cholestasis, which should prompt discontinuation of the combined hormonal contraceptive. We should routinely check liver concentrates after 3 or 6 weeks of such contraceptions. Okay, and progestin only. Contraceptives can be acceptable choice for women with history of ICP or cholestasis related to estrogen progesterone contraceptives. Women with history of cholestasis undergoing ovarian stimulation for in vitro fertilization may experience transient symptoms of cholestasis related to transiently high estrogens level, but data regarding the frequency of this phenomenon are sparse and limited to case reports. General recommendations for changes In a standard ovarian hyperstimulation, like stimulation protocols are not warranted for such women at this time. Progesterone supplementation is often prescribed to women with history of previous preterm birth or short cervical length in current pregnancy. It is uncertain whether to avoid progesterone supplementation in women with previous history of ICV. We make this decision with the patient after discussing individual risks and benefits, including consideration of her risk of preterm birth in the current pregnancy, likely gestational age of recurrent preterm birth with or without progesterone supplementation, and the risk of possible sequelae of recurrent ICV. If she decides to take a progesterone, we will discontinue if she develops intrahepatic cholestasis of pregnancy. So this was about intrahepatic cholestasis. Now we are going to discuss about dermatosis in pregnancy, and we will discuss dermatosis like pemphigoid gestationis, polymorphic eruption of pregnancy, atopic eruption of pregnancy, and pustular psoriasis of pregnancy. So how to evaluate a pregnant woman who has pruritic eruption? Pruritus is a major symptom, you all know. Although it may be physiologic and associated with common inflammatory skin disease, infection, infestations occurring coincidentally during pregnancy. Okay, so severe generalized pruritus, especially predominant on the palms and soles, in the absence of primary skin lesions, just intrahepatic cholestasis of pregnancy. A pregnant woman with pruritic skin eruptions requires immediate evaluation in consultation with dermatologist and diagnosis, because delayed diagnosis or misdiagnosis may pose significant risk to the fetus, like preterm delivery, small for gestational age, and it also pose risk to mother. So obtaining detailed medical history, including personal family history of atopic, obstetric history, and time of onset of eruptions, total body skin examination of the type and distribution of lesions, like eczematous lesions with flexural distribution suggest ectopic eruption of pregnancy. Involvement of stria is common in polymorphic eruption of pregnancy, and I am again repeating it. Involvement of stria is common in polymorphic eruption of pregnancy. Nodular lesions in the limb suggest prurigo of pregnancy. Urticaria lesions are most common with polymorphic eruption of pregnancy or pemphigoid gestationis, which can also display vesicular lesions. Skin biopsy for histopathic examination and direct immunofluorescence staining if the diagnosis is uncertain and pemphigoid gestationis is suspected. A skin biopsy should also be performed to confirm a clinical diagnosis of pustular psoriasis of pregnancy. Lab testing is indicated based on the clinical findings. If there is clinical suspicion of dermatosis associated with fetal and maternal risks such as pemphigoid gestationis, intrahepatic cholestasis, and generalized pustular psoriasis. So I am going to give you a brief overview about atopic pregnancy, eruptions in pregnancy, polymorphic eruption of pregnancy, pemphigoid gestationis, and intrahepatic cholestasis of pregnancy. How to differentiate between these four. Time of onset. Atopic eruption, 70% of cases before third trimester. Polymorphic eruption of pregnancy, last week of pregnancy or immediately postpartum. This is the onset time. Pemphigoid gestationis is also last trimester or postpartum. And intrahepatic cholestasis, as we have already discussed, it occurs in late pregnancy. Okay. And family history or personal history. Atopic eruption, there may be previous history as well, but in other cases there may not be. Okay. And clinical features. In atopic eruption, there 20% suffer from exacerbation of pre-existing atopic dermatitis with typical clinical features. 80% will experience atopic skin changes for the first time ever or after a long remission, that is after childhood eczema, with two main features like E-type and P-type. E-type, widespread eczematous lesions affecting typical atopic sites such as face, neck, upper chest and flexural surface of the extremities, and P-type, a small erythematous P-type disseminated on trunk and limbs, and typical prurigo nodules mostly located on the shins and arms. And about polymorphic eruption of pregnancy, there may be urticaria, papules and plaques. Arise from the stria. Okay, I am again repeating it. Arise from the stria distensi, usually on the abdomen, characteristically sparing the umbilical region. umbilical region. Why I am repeating it again? Because you have to differentiate it from pemphigoid gestationis, in which there is involvement of periumbilical involvement. But in polymorphic eruption there is no sparing of the umbilical periumbilical region, and there is involvement of the stria distancing in polymorphic eruption of pregnancy, which is unlike pemphigoid gestationis. After 1 or 2 days, the lesion spread also to the thigh or buttocks and may become frankly polymorphous. That's why it is called polymorphic, showing vesicles but never blisters. Remember that, never blisters, only vesicles. And this is again in contrast to pemphigoid gestationis, in which we see dense blisters. But there is also a spreading to trunk and extremities, but here no blister. You have to remember this point. And in polymorphic eruption, a non-urticated erythema, target-wide lesions, and E-type that I have talked previously, E-type. Okay. And about intrahepatic cholestasis, pruritus, and explosive secondary skin lesions like excoriation, prurigo, skin lesions. Okay. And what are the prognosis? Now let's discuss the difference about maternal prognosis, fetal prognosis, and recurrence in subsequent pregnancy. So in atopic eruption of pregnancy, maternal prognosis is unimpaired, and in polymorphic eruption there may also be maternal prognosis unimpaired. And in a pemphigoid gestationis, exacerbation or remission during pregnancy, flare up in 75% delivery, resolves within weeks to months but may recur with menstruation and hormonal contraception. Okay. And about intrahepatic cholestasis, risk for gallstone and intra and postpartum hemorrhage is there. And a recurrence in subsequent pregnancy. Atopic eruption can occur in subsequent pregnancy. Polymorphic eruption, no recurrence in subsequent pregnancy, but pemphigoid gestationis recurs in subsequent pregnancy, often with earlier onset and severe course. And intrahepatic cholestasis also recurs. And let's talk about fetal prognosis. In atopic eruption, there may be unaffected prognosis in fetus, but there is high risk of developing atopic skin changes later on. And about polymorphic eruption of pregnancy, excellent prognosis, no cutaneous involvement of the newborn. And in pemphigoid gestationis, there is increase for a small for death and premature babies. 10% of newborn develop mild skin lesions that resolves spontaneously within days to weeks. And about ICP, intrahepatic cholestasis, there is increased risk of prematurity, intrapartum fetal distress, and stillbirth that I have already talked previously, so I will not discuss more about this. And now I'm going to discuss about pemphigoid gestationis in detail, and then I'll discuss about polymorphic eruption of pregnancy, and then atopic eruption of pregnancy, and briefly touch again intrahepatic cholestasis of pregnancy, pustular psoriasis of pregnancy, and that's all. Let's discuss about pemphigoid gestationis. It is a rare autoimmune bullous disease that occurs during the second or third trimester of pregnancy and may be associated with increased fetal risk. And I have already told you that there may be also preterm birth. There is a high chance of that there may be preterm birth in pemphigoid gestationis. It is rare. Incidence has been estimated about 1 in 20,000 to 50,000 pregnancy. It only occurs during pregnancy or in minority of cases as a paraneoplastic woman in women with trophoblastic tumors. It is caused by circulating IgG1 autoantibodies directed against bullous pemphigoid antigen. Okay. As in bullous pemphigoid, the binding of autoantibodies to antigens within the basement membrane zones stimulates inflammatory cascade that results in separation of the epidermis from the dermis. In pemphigoid gestationis, the primary site of autoimmunity seems to be the placenta, as antibodies bind only to the basement membrane zone of the epidermis, but also to that of the chorionic and amniotic epithelia. So antibodies bind not only to basement membrane zone of epidermis, but also to the chorionic and amniotic epithelia, both of ectodermal origin. So it is just about pathogenesis, and in about clinical manifestations, it mostly often occurs in second or third trimesters. Intense pruritus may precede the onset of visible skin lesions. The rash typically begins on the trunk as urticarial plaques or papules surrounding the umbilicus. Okay, so I have already told you that it begins as periumbilical papules, vesicles, erosions, and crust. Okay, which is in contrast to polymorphic eruption of pregnancy. So there may be vesicles as well. Lesions may be seen on the palms and soles, but rarely on the face or mucous membrane. So it is not seen on the face and mucous membrane often. Okay? Eruption spreads rapidly and form tense blisters. So remember this tense blisters, which is in contrast to polymorphic eruption. There is no blisters, but in this there may be multiple tense bulla formation. That is why it is called pemphigoid gestationis, pemphigoid, bullous pemphigoid. Okay, here mucous membrane are usually spared, but other entire body surface may be involved. It may remit prior to delivery, however, about 75% of patients flare postpartum, and at least 25% subsequently flare with the use of oral contraceptives or during menses. Most cases spontaneously resolve in the weeks to months following delivery. The disease usually recurs with subsequent pregnancy and is often worse but may also escape pregnancy. And diagnosis is based on combination of clinical findings, examination of perilesional skin, of biopsy for routine histopathology and direct immunofluorescence and measurement of serum level of anti-bullous pemphigoid 180 antibodies by ELISA, and biopsy of vesiculating lesions reveals subepidermal vesicle with perivascular lymphocytic and eosinophilic infiltrates. Eosinophils may appear at the dermoepidermal junction and filling the vesicle. Okay, so you don't need those histopath informations. And now let's talk about a differential diagnosis. One is polymorphic eruption of pregnancy. The early urticarial plaques of pemphigoid gestationis are clinically and histologically indistinguishable from polymorphic eruption of pregnancy. A clinical clue to help differentiate between the two disorders is that polymorphic eruption of pregnancy often begins in the stria, while pemphigoid gestationis is truly periumbilical. And I have already told you previously, and I am again repeating again and again that because you should remember this point because it is most often asked in MCQs. Okay. Direct immunofluorescence of perilesional skin showing linear C3 deposition along the dermoepidermal junction and demonstration of circulating antibodies against bullous pemphigoid 180 by ELISA test will confirm the diagnosis of pemphigoid gestationis. So direct immunofluorescence and bullous pemphigoid antibodies are always negative in polymorphic eruption of pregnancy. Another differential is dermatitis herpetiformis, which is very pruritic, vesicular autoimmune skin eruption associated with gluten sensitivity. In contrast with pemphigoid gestationis, dermatitis herpetiformis lesions are usually located on the elbows, dorsal forearms, knees, scalp, backs and buttocks. Direct immunofluorescence of perilesional skin showing granular deposits of IgG-A with the dermal papilla confirms the diagnosis of dermatitis herpetiformis. Okay. And next differential is erythema multiforme, whether due to pregnancy, infection, or drugs, can mimic pemphigoid gestationis clinically, but routine histology usually distinguishes between the disorders. And another differential is allergic contact dermatitis and drug reactions can also appear similar to pemphigoid gestationis on physical examination. Thus, a careful history regarding the use of medications and exposure to environmental antigens may be helpful for the correct diagnosis. And let's discuss about the treatment and what is the prognosis of pemphigoid gestationis. So the treatment of pemphigoid gestationis, what is our goal is that to decrease the blister formation, promote healing, and relieve pruritus. That is our goal. So we suggest high potency topical steroids for initial therapy of localized disease. Okay, high potency topical steroids. If symptoms are not controlled by topical steroids, then systemic steroids like prednisolone are usually effective. Once the symptoms are stabilized, the dose may be tapered and even discontinued in some patients. However, reinstatement of treatment postpartum will likely be needed. The use of systemic steroids during pregnancy appears to be relatively safe. Although early studies suggest an association between systemic steroids and risk of miscarriage or congenital malformations, large population based studies have not confirmed this finding, so you should not worry about any teratogenic effect of steroid. You can give steroid in pregnancy to relieve these symptoms. Severe persistent postpartum pemphigoid gestationis may require higher dose of systemic steroids or alternative immunosuppressants. Prednisolone can be given until a clinical response is achieved and then tapered and maintained at the lowest effective dose. Alternative therapies that have been successfully used in few patients with severe persistent postpartum pemphigoid gestationis include aldehyde and high-dose immunoglobulins. First generation oral antihistamines like chlorpheniramine or second generations like loratadine cetirizine will be helpful for the symptomatic control of pruritus. And fetal prognosis is generally good despite increased risk of prematurity and a small for gestational age babies due to mild placental failure. There is no increased risk of miscarriage. In a retrospective cohort study of 61 pregnancies complicated by pemphigoid gestationis, 20 out of 58 live deliveries were classified as preterm births, and 19 out of 56 neonates with available birth with data were small for gestational age. Poor prognostic factors included disease onset in the first or second trimester and the presence of blisters on the mother's skin. In another study, 6 out of 32 pregnancies were complicated by preterm labor and 2 were associated with intrauterine growth restriction and 2 ended with abortion or stillbirth. Few newborns present with blisters, it is neonatal pemphigoid gestationis due to the transplacental passage of maternal IgG autoantibody. The eruption has a mild course and resolves within weeks without treatment. There is minimal risk of adrenal suppression in the newborn even if the mother has been maintained on high-dose steroids. The mother is at high risk of recurrent pemphigoid gestationis with subsequent pregnancy. And now we will discuss briefly about polymorphic eruption of pregnancy. What are its clinical features, how do we diagnose, and what are its differentials, treatment and prognosis. Briefly we'll touch about this. Okay. So this polymorphic eruption of pregnancy, and I will abbreviate PEP. So whenever I tell you PEP, you should remember that it is polymorphic eruption of pregnancy. Previously it was also called pruritic urticarial papules and plaques of pregnancy. It is benign, self-limiting, pruritic inflammatory disorder that usually affects primiparous women in the last few weeks of pregnancy or immediate postpartum. Toxic erythema of pregnancy, Bornese toxicemic rash of pregnancy, malignant IgM dermatosis of pregnancy, and nurse late onset prurigo are older terms held to represent the same entity. So it is relatively common. 3/4 of patients with classic type of PEP are nulliparous. The etiopathogenesis are known and may be heterogeneous. The degree of stretching of the abdominal stria may play a role. PEP is more common with excessive stretching, especially in women with multiple gestations. It has been hypothesized that stretching may cause damage to connective tissue, which may result in exposure of dermal antigens that trigger an inflammatory response. A role of reproductive hormones in the pathogenesis of this disease has not been demonstrated. Another possibility is that PEP represents an immunological response to circulating fetal antigens. As an example, one study demonstrated fetal male DNA in the maternal skin lesions, a possible result of blood chimerism. Fetal cells detected in maternal blood throughout pregnancy. However, this hypothesis has not been confirmed, although several studies have reported a preponderance of male fetus in women with And polymorphic eruption of pregnancy. Clinical manifestations usually occurs in nulliparous women late in third trimester but may develop postpartum. There are also rare case reports of first and second trimester disease. PEP typically represents an extremely pruritic erythematous papules within stria. I am again repeating it, within stria, which is in contrast to pemphigoid gestationis, which is periumbilical and does not involve stria. Abdominal stria are the most common initial site, with periumbilical sparing and maybe the only initial site. So I have repeated it multiple times, and now you should have memorized this point, and this point is very important. The lesion then spread to the extremity, chest, back, and coleus to form urticarial plaques. Okay? The face, palms, and soles are usually spared. White halos often surround the erythematous papules in patients with fair skin. Okay? So over the course of disease, approximately half of patients develop more polymorphic lesions, including target-like lesions exhibiting three distinct rings, colors, changes instead of halo or erythematous patches and vesicles. Eruption generally lasts 4 to 6 weeks and resolves within 2 weeks postpartum, although it may last longer or resolve prior to delivery. Diagnosis is usually clinical, based upon history and physical examination. A skin biopsy is generally not necessary for diagnosis of polymorphic eruption, and histopathology reveals perivascular and interstitial lymphocytic infiltrate containing eosinophils. And differential diagnosis, I have already talked about the differentials previously, and those are the same differential and how to distinguish between them. And treatment is symptomatic relief, high dose steroid, high potency topical steroids as initial therapy. Topical steroid can be applied once or twice daily until improvement occurs. The cumulative amounts of topical steroids used for the treatment of a specific body areas in adults, we have to calculate it. Cumulative amount used for the treatment of a specific body areas in adults, and you may also have read about those things. The safety of topical steroid use during pregnancy is supported by several observational studies and meta-analysis. However, the use of potent or superpotent topical steroids exceeding 300 grams during the whole pregnancy may be associated with increased risk of low birth weight. In severe cases, short course of systemic steroids with quick taper, such as prednisolone for 1 week, tapered over 1 to 2 weeks, may be given for rapid resolution of symptoms. Chlorpheniramine or second generation antihistamines, which are non-sedating, like loratadine, cetirizine, may be helpful to control pruritus. Early delivery to end system is rarely, if ever, necessary. And prognosis, it lasts for 4 to 6 weeks and resolves within 2 weeks postpartum, although it may last longer. In one series, the process resolved prior to delivery in 6 out of 15 patients. Polymorphic eruption pose no increased risk of fetal or maternal morbidity other than maternal pruritus, with no increased risk of fetal and maternal morbidity other than maternal pruritus, and recurrence is rare. Okay, and I will not discuss about atopic eruption of pregnancy in so much detail. Just I am touching it slightly, okay, because you may have already read about atopic eruptions. Atopic eruption is pruritic disorder that presents an eczematous or papular eruption in patients with atopic background. It starts during early pregnancy, with 75% of cases occurring before the third trimester, and tends to recur in subsequent pregnancy. Atopic eruption of pregnancy is a unifying term that includes eczema in pregnancy, prurigo pregnancy called prurigo gestationis, okay, and pruritic folliculitis of pregnancy, which were previously considered distinct entities, and it is the most common of pregnancy dermatosis, accounting for over 50% of all cases. That's why I touched it briefly, otherwise I would have skipped it. It, of course, it accounts for about over 50% of all cases. There may be personal or family history of atopy, and in most cases the first manifestation of atopic And skin changes. Atopic eruption is thought to be triggered by immunological changes associated with pregnancy, and it begins during the first or second trimester, and in most cases the first manifestation of atopic skin changes or the recurrence of atopic dermatitis after years of remission. In approximately 20% of cases, atopic eruption of pregnancy represents an exacerbation of pre-existing atopic dermatitis. Vast majority of patients with atopic eruption of pregnancy present with widespread eczematous eruptions involving face, neck, flexural area similar to classic atopic dermatitis. However, any area of the skin may be affected. A less common presentation of atopic eruption of pregnancy is prurigo of pregnancy, also called P-type atopic eruption of pregnancy, which presents with erythematous, excoriated nodules or papules on the extensor surface of the limbs and trunks. Lesions are grouped and may be crusted or appear eczematous. And let's talk about pruritic folliculitis of pregnancy. In rare cases, atopic eruption of pregnancy presents as follicular papulopustular eruptions. Scattered follicle-based papules and pustules appear initially on the abdomen but may spread to the trunk and extremities and may become generalized. The appearance is similar to that of steroid-induced acne and is only mildly pruritic. The eruption typically clears within 2 weeks of delivery. However, one reporter described a case with persistent symptoms for 6 weeks postpartum, and another series noted all 14 of the cases resolved prior to delivery. And diagnosis is clinical based on critical features. Okay, and differential diagnosis I have already discussed. I will not discuss again. And management is again steroids. And I have already discussed about intrahepatic cholestasis pregnancy, in which there is no primary skin changes, but there is maybe secondary skin changes. Okay, and ICP carries significant morbidity to fetus like prematurity, meconium stent, amniotic fluid, intrauterine demise, and increased risk of neonatal respiratory distress syndrome. And let's briefly talk about pustular psoriasis of pregnancy, formerly called impetigo herpetiformis, is an exceedingly rare variant or generalized pustular psoriasis occurring during pregnancy or triggered by pregnancy. It typically presents during the third trimester but may occur earlier or in the immediate postpartum period. It can occur any time during pregnancy but typically presents in the third trimester of pregnancy with symmetric erythematous plaques started at the periphery with sterile pustules in circinate pattern. The plaques then enlarge from the periphery at the center become eroded and crusted. There may be concentric ring of pustules. The pustules are typically sterile. Eruption begins in the flexural areas and spread centrifugally. The trunk are usually involved, with the hand, feet, and face are usually spared. Oral and esophageal erosions may occur. The nails may become onycholytic. Pitting can also has been described. Pruritus is usually absent. Systemic symptoms are severe and include malaise, fever, anorexia, nausea, vomiting, diarrhea, and tetany. Leukocytosis and elevated ESR are common. Hypocalcemia may be present, possibly related to hypoparathyroidism, and can lead to tetany, delirium, seizures. Okay. And diagnosis can be made clinically based upon history and physical examination. Okay. And management, because of the associated risk for the fetus, prompt institution of treatment is required for women with PPP, pustular psoriasis of pregnancy. Fetal monitoring with non-stress test or biophysical profile and ultrasound assessment of fetal growth are indicated. Okay. Low dose cyclosporin may be alternative to prednisolone for patients with pustular psoriasis of pregnancy. And about prognosis, it remits quickly postpartum but may flare after delivery. Placental insufficiency with severe sequelae such as miscarriage, fetal growth restriction, stillbirth may occur. Okay. So those were briefly about this pruritus and cholestasis in pregnancy. Okay, thank you.